We are going to discuss about a new topic. So, how many of you feel that we are not good at intubation? We couldn't able to intubate, and sometimes when we tried intubation, child went into cardiac arrest. So, like that, any of you people faced this situation in your practice? So one thing is I couldn't able to intubate, but when I am trying to intubate, I passed the tube very nicely, but post intubation, child was arrested. So how many of you people faced this situation? Can anyone share their experience? Hema, audio వస్తుందా?
వస్తుంది సార్, వస్తుంది.
Okay. No one tried intubation. All are perfect. 100% perfect intubations. No problems faced during intubation. Or if people don't want to reveal the imperfect intubations. PGs can talk. It's not an court, so that we can hide the. Because other has to join, just to prolong the discussion. We give 4 or 5 more minutes time for them to join, and we'll start the case discussion. Before that, just for interaction, anyone want to share their experience? No? Okay, I think all are having perfect intubation, so I think you don't need this class. But anyway, for people who not started intubation, it will be a learning lesson for them. So we'll move on to today's case-based discussion. This will be delivered by Dr. Balakrishna Pallanti. He is our consultant pediatrician and the cardiac intensivist. He did MBBS from JJ Medical College and MD Pediatrics from Narayana Medical College and PhD fellowship from Apollo Children's Hospital, Chennai. And after that, he worked as a senior fellow in Rainbow Children's Hospital, Bangalore. Then after that, he worked in Bangalore and he returned to Vijayawada and he is currently working with us for the last 1.5 years as a pediatric intensivist and cardiac intensivist. His areas interest was pediatric ventilation, shock, post-op cardiac management, difficult airway management, and cardiopulmonary interactions. And he had publications in IAP and IJBP as well. And he is a faculty. He participated in various CMEs and conferences. And I hope he will take you through the journey of a difficult intubation today. And I hope it should be an interactive session. And we'll continue this interactive session. And we need answers from all of you people. Don't be silent. And if you don't want to share your experience, at least you can share your answers with Dr. Balakrishna. Balakrishna, you can continue.
Good evening, everyone. So our topic of discussion will be regarding intubations and what is exactly going to happen. So I have faced it during my PG times, like whenever I intubated someone, like I thought everything was fine. And I used to feel myself I'm very good at intubation. So I have intubated like this, and I have faced scenarios where child went into cardiac arrest, where food was fine, everything was fine. So can we prevent it, and what are the different experiences which we had? So I'll just have a discussion. So I have taken 3 case scenarios. So we'll discuss briefly on how to manage, how to prevent the complications, and what actions can be taken. So first case scenario, a 2-year-old male child was brought to our hospital with complaints of increased work of breathing since 5 days, not accepting feeds well since 2 days, and altered sensorium since yesterday evening. So on arrival to our hospital, on initial pediatric assessment triangle, appearance wise is irritable, peripheries were cold, child had increased work of breathing. So what is your interpretation initially with these findings, and what do you intervene here? Anyone? So this is an unstable life-threatening condition, right? Because peripheries were cold, there is increased work of breathing, and appearance was child was irritable. So we initially started on oxygen with 5 liters, and we have asked it for IV access, and we moved to the primary assessment. So primary assessment, airway is maintained. Breathing wise, child respiratory rate is 50 per minute, definitely is tachypneic, and there are signs of nasal flaring, child is moaning. On auscultation, bilateral evidently is there, Wheeze is present. Saturation 82% on room air, and P-sats are 88% even with O2. Circulation wise, heart rate is 180 per minute, pulses low volume, CRT prolonged, and child BB is 86/50. So GCS, it is 12/15. So on exposure, he is febrile. So what is your primary assessment? So anyone? So
Sir, GCS is low and child is febrile. So there could be a possibility of CNS infection, and child is in compensated shock, and there is respiratory distress, like impending respiratory failure, sir. No, respiratory distress is there, sir.
yeah, there is definitely can be febrile encephalopathy, and child is having respiratory distress. He is having even signs of failure. There is nasal flaring, moaning is there. Even with O2 also is just getting saturation of 88, right? So circulation wise, so as you mentioned, heart rate is very high. It can be with fever, and it can be because of per se shock also. And the CRT is prolonged. So what you're going to do next? So child is definitely respiratory failure because there is moaning, and there are signs of respiratory failure such as nasal flaring, significant tachypnea. So, and child is in decompensated shock. Second is cerebral dysfunction because per se the shock and hypoxia had altered cerebral functions. So what you're going to intervene here? So initially you will ask the get a so we'll do a VBG, we'll do GRBS, we will ask them to give fluid bolus, start oxygen via face mask, and we need to prepare for intubation. So further course in ER, VBG is 7.15, PCO2 50, PaO2 40, bicarb 16, base deficit -9, lactate 3.5. So GRBS is 45 mg per deciliter, so we are giving 10% dextrose 2 ml per kg. So as such, we know all the child was in shock, so we have given 5 ml per kg and we have suspected cardiogenic shock, but vitals were same. But in view of persistent shock still, so we have given another fluid bolus. Child has this time worsened. So it's a common scenario which we face during our PG days, where child comes in shock. So we see the child is in shock, distress. So we try to give fluid bolus. Then definitely sometimes the child distress further worsens, shock will worsen. So here I have decided to go ahead with the intubation. So I have tried to give midazolam and succinylcholine. So I tried to intubate this child, and child went into cardiac arrest. So why do we think? So 4 things here. So what could be the reason for worsening after second fluid bolus? Anyone? This is a child who came with ER with distress, shock, compensated shock, respiratory failure. So we tried one bolus, there was not response. So we thought we'll give another bolus, but this time there was worsening. Why?
Any pulmonary edema, sir, or cardiac failure child, like giving bolus that is worsening the condition?
Yeah, that's one very good answer. So it can be because we already mentioned we are suspecting cardiogenic shock here, because in the clinical history with symptoms and vitals and all in the clinical examination, we thought it could be cardiogenic shock. So definitely, yeah, after second fluid bolus, pulmonary edema got worsened. So definitely the fluid bolus is not a good thing to do second time. I agree. Any other reasons?
Cardiogenic shock, sir.
Okay. So if you don't want to mention here, you can leave it in the chat box also. So what are your thoughts? So what is the reason for cardiac arrest in this child? What we did, everything was correct only, right? So child was in hypoxia, child was in hypotension. So we decided to intubate this child, which is a correct thing only, because if we wait for some more time, the child will land in cardiac arrest. So before that only we intubated. So we are given midazolam and succinylcholine. We are given sedation and analgesic, and we are given paralytic agent also. So what was the reason you think for cardiac arrest in this child?
Sir, like we had given midazolam.
Okay.
So if that can cause sometimes like hypotension. So without correcting the circulation, we intubated the child. So that might be a possibility, sir.
Yeah, you're correct. That is one of the reasons, because we did not correct hypotension and we directly went into intubation. Any other reason?
Any futures of raised ICP when midazolam given, sir?
No, because midazolam actually it's not going to cause raised ICP.
Or any manipulation, but there is no futures of ICP, sir.
Yeah. So one answer is correct. Child is in hypotension was not corrected, and we decided to intubate this child. So definitely that can be the cause. So any other cause?
Acidosis.
Yeah, acidosis is one cause. So as I told, bicar was I think 15 to 16. So definitely we did not correct acidosis. That can be one of the reasons for cardiac arrest. Any other cause?
Hypoxia, sir.
Yeah, hypoxia, hypotension, metabolic acidosis, all multifactorial are there in this particular child for reason for the cardiac arrest. So we need to correct all of these measures before we try to intubate this child. So what measures can be taken here to prevent the cardiac arrest in this particular child? So we all know we are treating a cardiogenic shock. So we all know child has worsened after second fluid bolus. So we decided to intubate because we thought we got scared. SATs are dropping, BP is dropping. So we decided to intubate. So he went into cardiac arrest. So what measures can be taken to prevent cardiac arrest? So one of you has mentioned midazolam. So do you want to give any other drug?
Fentanyl, sir.
Fentanyl is a good drug, but actually fentanyl is just an analgesic, more of an analgesic. It is less of a sedative. Because whenever you try to intubate someone, analgesic is not sufficient. You need to sedate and analgesia both. So, other than Fenta, because basically whenever you're suspecting cardiac, sorry. Any other drug?
Inotropes can be given, sir.
Yeah, that's a very good answer. We can start inotropes.
Ketamine.
Bicarbonate correction, sir.
Okay, starting inotropes. So starting inotropes, correction of acidosis, bicarbonate can be given. So any other measures to be taken further?
Pre-oxygenation.
Okay, pre-oxygenation has to be done because usually for this child it may pre-oxygenate no, because we got scared because after fluid bolus the hypotension worsened, hypoxia further worsened. So we thought, okay, no, we should intubate. So we did not correct any one of these and this thing. So we tried to intubate. So I have got answers in the chat box. Few of them have replied as ketamine. Yeah, ketamine is one nice drug of choice when you want to intubate. So just main thing which I want to stress out here is whenever you are trying to intubate a cardiogenic shock child, main thing is your already the catecholamines will be drained. So there is a deficit of catecholamines. Another thing is you want the heart function to slow down. So if the child is awake, child is restless and irritable, that can also further worsen his shock. So you want the child to be calm, sedated, so less workload on the heart, right? So whenever you are intubating someone, basically for respiration, you want the lungs to take rest. So decrease the workload on lung. So if you want to intubate for heart cause, you want to decrease workload on the heart. So these are the things, right? So whenever you want to intubate someone for these particular reasons. So what drugs are the best choice for intubating this child? So one everyone told ketamine. Along with ketamine, any other drug to be given?
Muscle relaxant.
Okay, muscle relaxant, which drug you want to choose? Because I have chosen succinylcholine, the child went into cardiac arrest. So any other drug?
Pancuronium can be also be given, sir.
Sorry, I can't hear you. Sorry.
Pancuronium or vicronium.
Okay, good drug. Okay, so what is the difference between succinylcholine and vicronium? Anyone?
Succinylcholine is long acting. Vicronium is short
Long
acting.
acting or vicronium is short acting? Which is long acting? Which is short acting?
Succinylcholine is long acting. Vicronium is short acting, sir.
Sure. Okay. So why actually this child worsened? Why actually this child went into cardiac arrest? So what will happen is usually the functional residual capacity will be very, very low because of already pulmonary edema. Everything is there. Above that, whenever you give the sedation, your FRC is further low. So the hypoxia cannot be tolerated at all. So once you give any sedative drugs, your area protective reflexes are gone. So that will further worsen the hypoxia and it can lead to cardiac arrest. So if you don't correct this, it can cause cardiac arrest. So hypotension, whatever drugs you choose, so some of them told Fenta, ketamine, whatever. So they will further vasodilate, so and cause a peripheral pooling of blood. And preload is significantly reduced, right? So because the blood is already pooled in the periphery, so systemic circulatory blood is reduced. And catecholamines are completely drained. So these are all multiple causes which actually can cause a child arrest. So how you manage hypoxia? So you use non-invasive positive pressure ventilation or non-rebreathing mask or Bain circuit, whichever you are comfortable with. So main thing is usually we have the habit of using bag and mask ventilation, but we don't use the PEEP. So there is a button above that. So if you press that, it will provide the PEEP. So recently I asked many PGs, so they will tell, sir, we usually do it when there is no chest raise. So what will happen is you are giving PEEP with that, which will actually improve your MAP, mean airway pressure. With that, it will open the closed alveoli. That will provide the nice oxygenation and it will give the chest raise. And main important thing which we tend to forget is whenever intubating someone, we'll give oxygen till then and we'll remove the oxygen after that. So we will usually try to intubate at saturations of 96 to 98%. So for 96 to 98%, usually if person is very good at intubation, one can intubate in maximum 15 to 20 seconds. So till that time, the saturation usually will drop till 90 to 90 for 96. So sometimes it can take more than 30 seconds. Sometimes it can take 45 seconds to intubate because with manipulation, cricoid pressure, many things. So at that time, the sats can drop to even 88, 84. So once it's dropped less than 88, the curve will drop. Within no time, the saturation will drop to 70 and there will be bradycardia. So how you prevent that? Administration of nasal oxygen during this brief apneic period to intubation will actually prevent the hypoxia. So hypotension management, fluid loading prior to intubation will actually prevent the development of hypotension by optimizing the cardiac preload. So how you assess that? You can use a bedside technique, any passive leg raise test. As many of you answered, best thing you need to use vasoactive agents because it will helpful in the hypotension which is caused by drugs due to intubation. So initial drug will be norepinephrine, but usually we'll start adrenaline when we suspect cardiogenic shock prior to intubation. So what are the drugs used? So best drug we usually use ketamine because dose is 1 to 2 mg per kg. The advantages are it is a potent analgesic and useful in traumatic brain injury cases also. And remember, ketamine does not cause rise ICP. It is very cardiostable drug, so you can use in any asthma cases on a respiratory wheeze or anything, or you can use in traumatic brain injury. You can use in cardio cases because it is a cardiostable drug. The main disadvantages are it can cause hypertension and tachycardia, and it sometimes can cause increased secretions. So with midazolam, it is actually a better amnesia and sedation drug, but sometimes it may cause hypotension. And Fenta, it is very fast acting. It is also relatively cardiostable. The main problem which we usually face is sometimes if you give fentanyl, it will cause chest wall rigidity. Sometimes you can't bag. So let's go to the second case scenario. It's a 7-year-old child who has presented to ER with vomitings for 2 days, hurried breathing for 1 day. Past history, there is increase in micturations in 7 days and increase in thirst in 7 days. So at arrival to hospital, initial assessment, appearance was drowsy, irritable, peripheries were cold, breathing, there is increased work of breathing. So what is your interpretation? So child presented with increased work of breathing, decrease in sensorium, and increase in micturation and increase in thirst in 7 days. Anyone? Is it stable or unstable child?
Unstable, sir.
Yeah, it's unstable child. Is it life-threatening?
It is life-threatening. Child is in shock.
Yeah, so peripheries are cold, there is increased work of breathing, GCS is not good. So definitely it is a life-threatening, unstable life-threatening condition, right? So what are you going to do?
Secure an IV line, give IV fluid bolus, check the CBG, and increase work of breathing, oxygen can be delivered.
Good. So go to the primary assessment. So airway is maintained. Breathing wise, respiratory rate of 50 per minute. Bilateral air entry is normal, no added sounds. Saturation 98% at room air, 99% even with oxygenation. Circulation wise, heart rate is 140. Low volume pulses. CRT is prolonged. BP is 96/60. Disability GCS is around 9/15. So GRBS is 560 milligram per deciliter. So what do you think? What do you think the diagnosis is here?
Diabetic ketoacidosis.
Okay. Any other causes?
Any crisis or like
Okay, your thought process is good. Can be. So main conditions, what are there here? On your primary assessment. So child is in.
there is no any respiratory cause, only tachypnea is there, sir. So
Okay,
it could be like acidotic breathing or something.
Okay.
And saturation on room air, bilateral equal air entry.
Okay. So child is in respiratory distress, right?
Yes, sir.
Yeah. So and there is metabolic acidosis. Okay. So why do you think GCS is poor here?
Polyuria is there, diuresis is there. So shock nala the child could be.
Yeah. So definitely there is shock. Definitely that can worsen your decreased cerebral blood flow. That can cause your poor GCS, right? So child is in severe respiratory distress. Child is in compensated shock. So it can be DKA. So we do VBG, do GRBS, urine ketones, fluid bolus. Then we'll start oxygen via face mask. So blood pressure is definitely on the lower side, but still child is in the compensated shock. So we did a VBG, pH of 6.9, PCO2 18, PO2 45, bicarb of 5, base deficit -18, lactate of 2.5, which is showing metabolic acidosis with compensated CO2 washout. So what are the problems anticipated here? Pre-intubation. Anyone? Because we decided to intubate this child. So what do you think the problems can occur? This time now we are clear because in the first case we have burnt our hands, we straight away in for intubation. So this time we are more careful and we decide, okay, what are the problems which can arise before you intubate this particular child? So what are the problems anticipated?
Hypovolemia.
Okay, good. So child is in shock, so we need to correct shock. Next.
We need to correct ketoacidosis also at first.
So I mean, in DKA, ketoacidosis definitely we need to correct, but we need to start insulin. It will take some time before your ketoacidosis is corrected because you know in DKA the metabolic acidosis is due to per se not because of loss of bicarbonate, but it is due to increased ketones in the body, right?
Yes, sir.
Yeah. So any other cause?
Hyperkalemia.
Will there be hyperkalemia in DKA?
Acidosis, because of acidosis.
Okay. So will acidosis cause hyperkalemia or hyperkalemia causes acidosis? Usually I used to have this question whenever in my PG days, because my concern used to ask whether acidosis will cause hyperkalemia or hyperkalemia will cause acidosis. Anyone? Because he has made a valid point, hyperkalemia. Definitely it can be hyperkalemia, but if you see hyperkalemia, what you're going to see in this particular child here, because it's a common scenario which we face. It is out of discussion, but I just wanted to clarify. So you don't do if you see hyperkalemia. Anyone?
Acidosis will cause hyperkalemia. Sir.
Why?
In order to lose H+ ions, there will be retention of potassium.
Yeah. So usually with metabolic acidosis will have hyperkalemia because so what will happen in metabolic acidosis? Your H+ is high. So to throw that, they will retain the potassium. I agree. So another common cause which we face during this particular scenario. So as I have mentioned here, there is hypotension, right? Child is in hypotension. As we all know, it is DKA, straightforward. So child is definitely hypovolemic because child is having increased micturition. Definitely child wouldn't have taken much fluids orally. So sometimes even in hypovolemic patients, usually we'll get squeezed sample. So there will be no much flow when you try to take the sample. So sometimes that squeezed sample also will be hyperkalemia. So if you see hyperkalemia, try to see the sample. Usually most of the times if you hypovolemia, out of 100 times, how good you are, how good the person who is putting a cannula, if you put a large bore cannula, doesn't matter. Out of 100 times, 60 times I have seen hyperkalemia. But immediately I repeated, within 2 hours again the potassium is normal. Just want to clarify that. So as we all mentioned, the problems here are, one is hypotension. One of you has mentioned definitely there is metabolic acidosis. So any other problems?
Because there may be apnea, the PCO2 may rise, so that rise may cause sudden, like it may worsen acidosis.
Okay, good. So what are the precautions you will take before intubation? So now you know all the problems, right? So you are worried about hypoxia, you are worried about hypotension, you are worried about acidosis. So what are the problems you're going to take? So one of you has mentioned even nicely regarding the rise of PCO2. I totally agree. So why do you think PCO2 is rising? I mean, is rising when you decide to intubate someone? Because I have intubated many respiratory cases with PCO2 of 75, 80, but post intubation, my PCO2s are fine. So what are the precautions you will take before you intubate this child?
Correction of shock and pre-oxygenation.
Okay. Good. Next, anyone? So usually you will correct the shock. You need to correct your acidosis. Definitely. So, and I mentioned about the apneic oxygenation. Anyone?
We can give IV fluid, sir. If there is anything like very profound acidosis, can we give bicarbonate infusion, sir?
Actually, now in this particular case of DK, actually I have taken this scenario so that people will understand. Usually in DK, we don't give bicarb. The reason is
only IV fluid will be giving. But
yeah.
if it's like severe acidosis prior to intubation, is there an indication to give, sir?
No, in such cases also usually we try to avoid that, because as you all know, the worsened GCS is because of cerebral edema. The cerebral edema is per se because of the hyponatremia, because of fractures rise in the hyperglycemia. I don't want to go into deep pathophysiology, but this is the reason. So usually why we avoid giving sodium bicarbonate during DKA is, so finally your sodium bicarbonate is nothing but, if you try to remember your chemistry, it is finally H2O, H plus plus HCO3 minus. Again, that is going into H2O plus CO2. Am I clear? So you are giving sodium bicarbonate, which is again, that is the reason when you give sodium bicarbonate, why your sodium rises, it has sodium inside within it. So what will happen to the remaining H2CO3? It will differentiate into H2O plus CO2. So again, the CO2 will be raised. That is usually avoid bicarbonate. But if this is a case where usually we see these scenarios where you see a 3 years old or maybe 1 year old or 9 months baby, where you see the same history, child was fine, well thriving child, suddenly child has some cough, cold or fever, suddenly they will be worsening distress, suspecting IEM, then you need to give bicarbonate. Am I clear?
Yes, sir.
So somebody has mentioned nicely, so PCO2 will go up. So what is the reason? When there is severe metabolic acidosis, when there is pH of 6.9, in this particular case, PCO2 is 18, so child is hyperventilating definitely. And that will wash out the PCO2. But how much you try to hyperventilate also, it will only reduce this much. But you have given some drugs to intubate. Some wants to give ketamine, I am fine, Fenta, you are fine, whatever. So you have given that drug. So I told you, right? So how much you will bag? So usually I have myself, I will bag with the normal rate of 30. irrespective of PCO2 level. Sometimes even myself being a consultant also, I'll bag at 30. And sometimes I'll see where my PGs will be bagging at 20 because I'll bag for 5 minutes. So I can give to my PG so that he'll bag, okay, so that I can take rest. So he'll be bagging at 20. Sometimes he'll bag at 50, sometimes he or she will bag at 20. So what will happen, all this is because already your pH is low, they're compensating by PCO2 washout. So you intubated someone during the brief apnea, it will be at least 15 seconds brief period because you intubate, you check the tube position, then you connect the bag, you start bagging and person changing positions. So this all will cause further fall in the pH because your PCO2 will rise, right? Because you have taken away all the rate which the child is breathing. So what will happen next? So you take the gas, pH is 6.7, your PCO2 is 38. So whatever rate you set may not match with your physiological rate. So we need to bag the child at supraphysiological rate. So whenever you're intubating particular scenario cases, so you need to give supraphysiological rates. So if the child is initially breathing before you intubate at 40, try to give 45 rate. In that way, you can maintain your PCO2 so that there will be not much drop in the pH. So if you repeat the gas, same person, if you give it supraphysiological effort, your pH will be 7, your PCO2 will be 16. So it is good gas, right? So in the meanwhile, you will start insulin, you will start corrections, fluid bolus. Definitely your bicarb will get better. At the same time, your pH will get better. Clear on this scenario? All of you understood?
Yes, sir.
So what are the recommendations from my side? So usually in particular cases of DK, usually we try to avoid the intubation and use of NIV. Try to avoid the spontaneous respiration because sometimes you have seen kids where they breathe at 50, 60 also. I can't give 60, 70 rate myself. So try to avoid that and use of NIV and try to make spontaneous respirations. Avoid use of long-acting muscle relaxants such as rocuronium or pancuronium. So fluid bolus definitely you need to give. I just mentioned here, usually in DK we don't give bicarb corrections, but if it is the same scenario where you suspect IEM, you need to give bicarb correction and early start of inotropes. Not in this case, but in case of IEM. So with that, we have completed 2 case scenarios. So just briefly, so you are suspecting a physiological difficult airway, hypoxia, give apneic oxygenation, and use of bag and mask ventilation, give PEEP. So I have seen many people usually they don't give PEEP. I have seen 2-3 people answering to me when they will tell, sir, I will use that button only if there is no chest raise. So that actually will give PEEP, that will open your closed alveoli. Definitely then you will see the SATs are getting picked up nicely. Hypotension, you need to optimize your hemodynamics by giving fluid boluses. So if you're suspecting cardiogenic shock, I suggest myself to go slowly, give 5 ml, see the response, then another 5 ml. If the response is there, give. If you're suspecting hypovolemic or distributed shock, you can go ahead with 10 ml per kg. If slightly bigger child, you can see the response. If you do like a passive leg raise test near the bedside. Clinically, how are you going to see the response with the fluids? The heart rate will come down and there will be some response in the BP. And early use of inotropes. So metabolic acidosis, how you will correct is you need to correct your acidosis by giving sodium bicarb. And one more point is, as I already clearly mentioned in the last slide, so rate, we need to give definitely supraphysiological rate. This particular child, it's okay because as I mentioned here, GCS is 9/15, so I can wait on intubating this child. So sometimes your scenario where your GCS is 7, so you need to intubate this child. In that particular cases, give supraphysiological rate so that your pH won't drop and it will cause further worsening and it can lead to cardiac arrest. So going into the another case discussion. So is it clear to all of you regarding what we are discussing? So we'll go to the third case discussion. A 5-year-old child who is a known case of some genetic disorder now came with increased work-out breathing since 3 days, decreased intake of heat since 1 day. The child has distress worsened since last evening. So he's a known case of genetic disorder, increased work-out breathing, and distress worsened since last evening. So a arrival to hospital, initial assessment triangle, appearance is irritable, peripheries were cold, there is increased work-out breathing. So what is your interpretation and how do you intervention this child?
Unstable, life threatening.
Yeah, so it's unstable, life-threatening child. So how do you intervene? So you need to start oxygen, you need to ask for IV access, and you need to move for the primary assessment. The primary assessment, airway is maintained, breathing wise, child having respiratory rate of 50, child is moaning, nasal flaring is there, bilateral air entry is present. Saturation wise, 82% at room air, with oxygen it is 90%. Circulation wise, heart rate is 140, low volume pulses, CRT is prolonged, BP is on the lower side, 86/46. Disability wise, GCSE is 8/15. On exposure, cold peripheries were there. So what is your assessment of this child? So what is your assessment of this child?
Respiratory distress is there, sir.
Okay.
And impending failure, like there is moaning is there, and saturation like 90% with oxygen. And second is like tachycardia and shock is there. And cold peripheries, we can think CBG values, so we can check the CBG for this one.
Yeah, CBG value I checked, CBG is normal. Sorry, capillary blood gas. Okay, so capillary blood gas we have done. So capillary blood gas is showing pH of 7.2, PCO2 of 38. Sorry, PCO2 of 50, PO2 of 45. You can just tell the assessment. So you're correct in the assessment part. So child is on severe respiratory distress on the verge of respiratory failure. There is decompensated shock. As I have mentioned here, child is a known case of some genetic disorder which we don't know. So definitely there is primary cerebral dysfunction. So we do the capillary blood gas or VBG, fluid bolus, oxygenation via face mask. So this particular child, we have secured IV access, given fluid bolus of 10 ml per kg, continued on O2 via face mask. So we decided to intubate this particular child. So we have given Midaz and Vectronium. We started bag and mask ventilation, but couldn't able to get the chest rise. So how many of you faced any scenario where you're intubating someone where you did bag and mask? So you used PEEP also, but still you couldn't get the chest rise.
Seal won't be proper, sir.
That's very good answer. Any other answers?
Sometimes the oxygen they won't turn on, sir. Sometimes it happens.
Yeah, so you need to check whether if you're using NRM, so if you need to be filled or not. And chest rise, why you could not get chest rise?
Proper head, like head tilt and shoulder roll, sir. Like.
Yeah, okay. Next. I faced it. One thing which you told very nicely was proper mask seal. So which usually we don't do. We straight away put the mask and we think that we can bag. So any other causes, anyone?
Position of the tube, ET tube.
No, it is only bag and mask still. We did not intubate.
Oh, okay.
We decided to intubate, so given we started bag and mask, but couldn't get chest rise still.
Tongue fall back or airway closure.
Okay, any airway obstruction. Okay. Anyone wants to contribute further?
Neck flexion.
Neck flexion, shoulder roll. Yeah. One of them has mentioned it as dope. So dope usually we do it when we post intubate when we don't see the chest rise. So dope is nothing but displacement, obstruction, pneumothorax, equipment failure, as we all know. But usually we do it when we intubate and we don't see the chest rise. ET tube inside. So one of them has answered nicely. So you need to see MR SOPA. So MR SOPA, as everyone mentioned, you need to adjust the mask properly, reposition the head to open the airway. Suction is also very, very important, and open mouth and lift the jaw forward, because sometimes there will be tongue fallback. And you need to increase the pressure also. As I mentioned, sometimes your pressure may not be also sufficient when you can't see the chest rise. And arrange for artificial airway. So what do you do when you see a difficult mask ventilation? So you start administering 100% oxygen. As I have told you, you need to check for the equipment. So equipment malfunction is there, you need to switch to self-inflating bag. If there is no malfunction of the equipment, you need to check the patient. As I have told, do MR SOPA here, adjusting the tricord pressure, 2% bag and mal mask, shoulder roll. So still it is unresolved. Then you immediately need to call for help, and you need to reassess the child. So as I have told you, everyone told about MR SOPA, we need to adjust position, suctioning, everything we did, but still the issue is not resolved. So definitely you need to call for help. So you need to assess the child again. So I have faced this scenario 1 to 2 times. So you need to rule out any upper airway obstruction. If that is the case, you need to place any supraglottic airway or oral airway. If there is no upper airway obstruction, sometimes we have faced this scenario where there is a laryngospasm or bronchospasm. So sometimes you might be sedated and given analgesic, but sometimes you don't give sufficient paralysis. So if you don't give sufficient muscle relaxant also, you will feel the laryngospasm. So you won't see the chest rise. So you need to increase the sedation dose, and you need to increase and give a muscle relaxant also, and continue CPAP. Sometimes fentanyl also will cause this bronchospasm, chest wall rigidity. So be careful when you did everything, you are ruled out upper airway obstruction, you are given nice sedation, but sometimes what will happen with Fenta, it can cause chest wall rigidity where you can't do bag and mask ventilation properly. So you did MR SOPA. So now after adjusting the mask properly and doing proper suctioning of the oral cavity, now able to do bag and mask, you are getting nice chest rise. Now you decide, okay, fine, everything is good. So you decide to intubate this child. So, but now you failed in the intubation. So what to do next? So what you will do if you fail in the intubation now?
Either change the technique or change the hand.
Okay, sir. Next, anyone?
We can see the size of the tube, and after visualizing proper vocal cord, we should place. Sometimes it could be an esophageal intubation.
Okay, good. So sometimes, usually, whenever you failed in intubation, the first thing the person who is intubating thinks that he can't intubate, he or she. That is actually not correct. You need to see the technique. The technique should be correct. So after technique, then you need to select a proper laryngoscope blade. Sometimes if you select a one size blade for an infant, sometimes you are crossing the vocal cords and you will be seeing esophagus and you couldn't visualize the vocal cords. Sometimes you select a 00 blade for an infant, again it will be a problem. So you can't lift properly and you can't visualize the vocal cords properly, right? So any other causes? And another thing which we need to remember here is proper size of DT tube. Sometimes if you select the wrong size, wrong blade, and wrong technique, these three things need to be looked for. So you need to tell to the other person why I have failed in this particular technique, why I couldn't intubate. So these things ruled out. Then what else you need to think?
Difficult airway.
Okay, what do you mean exactly by difficult airway?
Any prior edema over the cords?
Okay, so it can be breast child, sometimes anteriorly placed vocal cords.
Improper sedation, like the child doesn't go to complete paralysis, that could be.
Yeah, we have ruled out, right? So we did the MR SOPA, so I told you, so we have ruled out that also. So we sedated nicely, we have given paralysis nicely, everything is proper. So we are able to get chest rise also, but we failed in the intubation part.
Laryngospasm.
Yeah, we have ruled that also, right? So I was telling you previous slide. So difficult mask ventilation is this. So if laryngospasm, you can't get chest rise also. So failed endotracheal intubation. Again, you need to, as I was telling you, repeat laryngoscopy. Avoid repeated attempts. So check your position. External airway manipulation is important. As two or three of you have mentioned, different blade or different handle needs to be checked. Still, if that is poor view is there, if you follow all the things, then you need to intubating using supraglottic airway. Or if you can use indirect video laryngoscopy if you have available, or fiber optic bronchoscopy. If it is difficult, then take the supraglottic airway. If the patient is stable, awaken the patient. Give muscle power. If you have paralysis of the child, give reversal. So patient will definitely get awake after some time. So you remove that. So if your unstable hemodynamics or still hypoxia is there, you need to switch to cannot intubate, cannot ventilate. So unanticipated, cannot intubate, cannot ventilate child. So you need to call for help. So you need to see whether patient is stable or unstable. If patient is stable, SATs are maintaining, no bradycardia, no cardiac arrest, awaken the patient. So you need to give Sugammadex, which is reversal. Then you can awaken the patient. If the patient is unstable, there is bradycardia, impending cardiac arrest, hemodynamic instability. You need to call for the ENT help. Immediately call for help when you cannot intubate or cannot ventilate someone. So if surgery is available, try for surgical tracheostomy. If surgery is not available, then you can try for needle cricothyroidotomy. So when we will anticipate the anatomical difficult airway, this which we faced was unanticipated, right? Because we thought everything was fine, so we decided to intubate this particular
బ్యూటిఫుల్ బాయ్స్ మూడు తెలుసుకున్నాను.
So anyone, when we will anticipate the difficult airway anatomically?
Peary Robbins sequelae or Peary Robinson's.
Yeah. Okay.
Even obese child, sir, like adolescent obese child.
Yeah. Good. Anyone? Any other answers?
Large tongue.
Yeah, definitely large tongue. Short neck. So anyone further? So there are two things. So one is unanticipated. So you don't know. So previously we decided to intubate. So first initially we could not bag. Then we did MR SOPA. Then we checked everything, suction, everything was fine, proper sedation. Then we decided to intubate. But this is like anticipation. So when you will anticipate. So difficult airway, when you are anticipated difficult airway, difficult to with laryngoscopy, look externally, evaluation is done with 332 score. I'll show you that. Mallampati score, as everyone pointed out, obesity. You need to see the neck mobility. If you are unable to do the bag and wall mask seal, obstruction, obesity, no teeth. If there is problem in placing the anticipated supraglottic devices also, restricted mouth opening can be there. There can be tube obstruction. Sorry, if the airway obstruction, sometimes it can be distorted or disrupted airway also will cause this particular scenario. So you anticipate everything, still you are unable to do cricothyroidotomy. Sometimes it can be hematoma, obesity, or it can be tumor also. So this is the Mallampati scale. As you see, you can visualize this if you are anticipating a difficult airway. So this is grade 1 where you can see the laryngeal view. So grade 2, grade 3, if you are grade 4 with the large tongue. So there is a difficult view. So you can anticipate the difficult view and you can arrange for help. So this is the 3-3-2 rule where you can check initially before intubation when you are anticipated difficult airway. So 3 fingers from the cricoid through the mentum, and 2 fingers at the thyroid, cricoid and thyroid. So 3-3-2 it can be done. So final thing is whenever you decide to intubate someone, you need to remember SOAP me. You need to see for suction, it needs to be placed in anchor suction. Then you need to have NRBM mask. There should be nasal cannula. Airway, there should be 2 ETT expected size and 1 size below and 1 size above. And there should be, if you have devices, you need to have less rescue devices such as LMA, or sometimes scalpel might be there because if you anticipate and you want to do cricothyroidotomy, and you need to check the position. You need to do continuous monitoring need to be there. You need to make sure all the drugs are available. And other equipment such as Boogie need to be there. 2 laryngoscope blades need to be there. If you have all these things, so whatever your problems are there during difficult airway, all can be prevented. The mnemonic is SOAP me. So take home messages. Do think of a physiological difficult airway while intubating a sick case. Optimize hypoxia, hypotension, metabolic acidosis before intubation. Start inotropes early after initial optimization of fluids. In case of metabolic acidosis, give supraphysiological rate while bagging. That is the most important thing to avoid further drop and worsening the condition. So anticipate the anatomical difficult airway when you have structural abnormalities in face and around neck. And remember one thing, all are not superheroes. Really, that is the thing which we have. Call for help when needed. So most of the time you can intubate, I totally agree. But you need to remember you have to call for help when you are facing a difficult scenario. Sometimes you can't bag and mask, sometimes you can't, you might be forgetting, okay, I'm doing everything, you might be forgotten about paralysis. So other person will tell and give that, so that will be helpful. So call for help when needed. Thank you everyone. So any questions?
So only one doubt, sir. In case of DK also, and in the last slide also, we have mentioned like that supraphysiological rate of like bagging. So that helps in metabolic acidosis. That concept alone, like little doubtful, sir.
No, actually, if a DK child, remember you decided to intubate, right? So your pH initially due to pH was 6.9, your PCO2s are 18.
Okay, sir.
So you decided to intubate this child because child sensorium is very poor. GCS is 5, 6, whatever. So
okay,
child is breathing at initially 40, 45 rate, right? When the child came to, usually DK will be around 6 to 7 years age.
Okay,
so
sir.
He is breathing at 40, 45. Usually when you intubate, you usually how much rate you will give? 30, right? Maximum 30, 35.
Yes, sir.
Yeah, usually you don't give more than that. So what will happen in this particular child if you give same 30, 35? So you are already, you have this apnea stage where your PCO2 will definitely go high. If you don't intubate, at least you take 30 seconds to intubate, connect everything. So during that time, your PCO2s already might have gone up, right? Previously, it was only 18. And the child is breathing at 45. So during this period, definitely your PaCO2 post-paralytic, it would have gone up to 35. Right? So when you post-intubation, you are giving the rate of 30. Will the PCO2 come down? Definitely not. So PCO2 will be maintaining at 35. Previously, your PCO2 18 with compensation, your pH is maintained at 6.9. Post that, your PCO2 has increased to 35. So what will happen to your pH? Definitely it will further drop. So it can drop to 6.8, 6.7. It will further worsen the condition. So you need to give the rate with the child is breathing before you intubate.
Okay,
so that no CO2 rise and no further pH drop.
Okay, sir. Okay, sir. Yes, sir.
To make it simple, just one that point. What is the target CO2 you are targeting there in the child DKA? They had 6.9 pH and your CO2 was 16 or 18 pre-intubation. So during intubation, post-intubation, what is the target CO2 you are targeting? Because of riser recipe, you are targeting 35 CO2. or you are targeting what is the previous CO2 pre-intubation? If you answer this question, then you answer the concept. So what is the normal CO2 target in LDC?
Normally, it's like 35 to 45, but we might expect the previous one, sir, to maintain the pH.
Exactly. So the reason for cardiac arrest in this child is drop in pH due to your rise in CO2.
Okay, sir.
Your target is previous CO2.
Okay,
So you
sir.
have to maintain there. So child was maintaining it there by breathing at supraphysiological rate. Child was not breathing at normal rate.
Okay, sir.
We have seen acidotic child who is breathing at a 45 to 50 rates. And
Okay, sir.
post intubation, if you try to give physiological rates, it will not maintain the CO2.
Okay, sir.
That's why you have to match the rate what the child is breathing at. So you need to count. That's the most important thing before intubating any IEM child or DKA child. You need to count the respiratory rate what child is breathing at.
Okay, sir.
And how much amount of the chest rise he is getting. He's maybe maintaining his minute ventilation by increasing rate and increasing volume. So that's why when post ventilation also you need to go for the same volume and same rate, not the normal rates, normal volumes. Even 6 ml per kg, 7 ml per kg will not be sufficient for that child. So not only rate, match the volume as well. So you need to go for the high chest rise, normal, not normal chest rise. You need to go for a little bit high chest rise and with more rate.
Okay, sir.
What you are
Sure,
trying
sir.
is you are matching the minute ventilation what child is trying to maintain before intubation. That's all. The simple answer is that thing. You have to match the minute ventilation. The minute ventilation contains the rate as well as volume.
Okay, okay, sir. Yes, sir.
Any other questions?
To assess that airway 332 rule, any minimum is, sir?
No, usually we do it from the age of 1 year, because less than 1 year you can't see for the neck and all, because sometimes there will be short neck, fat and all. Usually the age we see is from 1 year.
Okay, sir. Thank you.
Any more questions? Okay, thank you everyone.
Thank you, Dr. Balakrishna. It was a very lucid presentation. Explained about the difficult scenarios we commonly face during intubation. And I hope you people got something, some points where we do commonly mistakes during intubation, because I have also faced the same situations. I have very well done with intubation and I put the tube correctly into the use of the trachea. I'm bagging, chest rise was there, but child was arrested. So many times we have faced this situation. So we need to modify our intubation techniques, and we have to anticipate the difficult airways, and not only anatomical, physiological. We often forget physiological difficult airways. So make sure that next time when you're intubating, you are optimizing the child for intubation, not only hemodynamics, everything. So you need to optimize the child's condition to favor the intubation, to make the child go through the phase of intubation, the stress of intubation. So make a habit that, so to keep a checklist. So you have to make a checklist so that you have to keep ticking the check boxes. So what are the problems we'll anticipate in this child? So what are the things I have to make ready? So what is the optimization of this child? The plan for optimization. It could be hemodynamics, it could be hypoxia optimization, it could be metabolic acidosis optimization, or it could be difficult anticipated airway optimization, anatomical airway optimization. So you need to make a plan. So I can share the checklist in the group. So please go through the checklist. So it's very important. So we need to anticipate the problem and we have to prepare for that. So that only way you can prevent this unanticipated arrest in a process of intubation. Thank you. Thank you, Dr. Balakrishna once again.
Thank you.
So we'll conclude the meeting.